Good afternoon, everybody. We are going to get started here. So welcome to the Reproductive and Family Planning for Clients with Disabilities webinar. My name is Megan Arias, and I am the Training and Organizational Development Manager here at HCET, and I will be facilitating the webinar today. So I'm just going to briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate, reproductive and sexual health education, training, and care is a fundamental right. So today's webinar offers nursing contact hours, and in order to receive nursing contact hours, you as a participant must attend the entire webinar, return the completed participant evaluation and post-test, and complete the nursing contact hour form and email it to kbradford@hcet.org. And this form will be included in the follow-up email after this webinar concludes, as well as this information. So you know what to do in order to receive nursing contact hours. So no one with the ability to control contents of this activity has a relevant financial relationship to disclose with an ineligible company. So now I'd like to introduce you to our presenter today, Robin Wilson-Beattie. As a woman of color with hidden and visible disabilities advocating for diversity and inclusion in society, is Robin's lived experience. With a professional background of teaching disability, self and systems advocacy, her groundbreaking and revolutionary work in disability and sexual and reproductive health, early employment in corporate America, Robin has learned the importance of empowering people to advocate for better access in their communities. Her educational background is in anthropology, sexual and reproductive health, and law. All of this has gifted her with a unique perspective and outlook on how we can all learn and support each other in being together. So without further ado, I will pass things over to Robin to kick us off.
Unmute. Yes. Hi. Next slide. I am who am I? Hi, everyone. Thank you very much for inviting me to present at this webinar today. My name is Robin Wilson-Beattie, and my pronouns are she and her. I am a disability, sexuality, and reproductive health educator, speaker, and writer, and I enjoy talking about and educating and learning about all things that intersect with disability and sexuality. I am a disabled person. I am multiply disabled. I have hidden disabilities as in mental health, and I have ADHD. And I also have physical disabilities, which manifest and as in like a spinal cord injury. So I am a proud mama of one child, and I love going to thrift stores and because I love vintage and I'm very good at finding what I want. So next slide. So when we're talking about disability, you're going, what is disability? Now, disability has different models or perspectives, basically, on what disability is. You have your medical model, which as healthcare professionals, this is one that you're probably most familiar with, which is the definition is it's diagnosis-based. And it's a diagnosis-based perspective where disability is explained as a biological issue due to genetic disorders or disease or trauma, or other health conditions. And legal law type, they tend to borrow from the medical definition of disability in order to give people access to benefits, like disability benefits, but also in accessing accommodations for education. And so they, like, you have like school or like special ed, or, you know, in order to get those services or whatever, needing a medical diagnosis of a disability in order to receive the assistance. Now, however, that tends to it looks at disability, it overlooks like the design decisions that, you know, make things disabled. For instance, if we're looking at stairs, I'll use stairs as an example, the impact, the disabilities that don't look at the whole picture of how society is designed for able-bodied people and how it excludes disability, therefore making the disability, you know, part of the social design as well. So, and making disability the person's problem rather than environment. So that's where you go into like a social model. And the social model perspective, it views disability as a condition that is created by bad design, and that society is the one that puts up barriers, like, you know, the example I used of stairs. And this model, you know, it rallies for change, and like this cultural and the changing the cultural ideology and how you think about disability, and changing it to be society to be more inclusive. However, some of the weaknesses of that model, and, you know, in all these models, you know, they have different weaknesses and strengths, but it strips disability from a person's identity, and it de-emphasizes the real biological impact of and realities of disability. That, yes, society, you know, there can be these social barriers, but, you know, disability, you know, as, you know, the biological process as a disability, those are very real. And we can think all we want about it and be inclusive, but, you know, it's still going to exist. So therefore, in 2020, I saw this, there's a holistic model of disability where it is inclusive of both the biological and the social, and where it's talking about how disability is any physical, neurological, mental, intellectual, or sensory impairment and or condition that by itself or in interaction with additional inherent or other outside factors may interfere with full, effective, and equal participation in society. And disability, and it also gives voice to the fact that disability can be temporary or it can be permanent. It can be present at birth or acquired at any point later in life. So that's, and then you have other models too, where you can, you know, you have these religious and moral perspectives on disability. You know, some there, you know, there's like a religious and moral where it looks at disability as like a punishment, you know, and therefore stigmatizing it. Or you have an economic model where they are defining disability by or this perspective of disability is defined by the perspective of whether you're able to work, and inability to perform work that earns money, and contributing monetarily to society. And so that stigmatizes a person, you know, somebody disabled as someone who is needy. And, you know, that also ties into like the charity and tragedy models. So, you know, those are different ways that people look at it. But so that kind of gives you an idea of different ways of looking at disability. Next slide, please. However, but we're talking about sexuality, sex ed, and reproductive and sexual health care. So some of the sex ed barriers when it comes to disability are the desexualizing attitudes regarding disabled sexuality. There are myths that are, sometimes prevalent in society, um, regarding disabled sexuality that, oh, wait, people with disabilities have sex, and um, equating being able to engage in sexual behavior or things as in views of, oh, but you're disabled, so how would somebody want you, that sort of thing, and looking at it from that perspective. Also tending to infantilize people with disabilities. If like, oh, well, you have to be protected like children and being protected from sex, and this is bad for you. Or, sometimes you have attitudes of people that people go, oh, well, you have a disability, so, sex should be like the last thing you're thinking about. So the other thing is, giving sex ed only from a protective view, like only for preventing abuse or preventing pregnancy or preventing disease, but not inclusive of pleasure, or healthy sexuality and expression of sexuality. There's a lack of support in teaching disabled sex ed, and not just, but there's also a lack of support in teaching sex ed in general, with whether you have a disability or don't have a disability. As you see that, because sexual health education is not mandatory in every state. And so you have some places, and then also the types of sex education, or what you're allowed to talk about and what you're allowed to teach. You also, people are products of our culture, and educators are embarrassed to talk about sex and disability. Educators feel that sex ed and disability should be taught by healthcare professionals. So therefore, passing the buck on to like rehabilitation specialists, or, physical therapists, or doctors, nurses, or, other healthcare professionals. And also some of the diversity of the disabled experience. You meet one person with a disability, you've met one person with a disability. And not all disabilities are going to be manifested in the same way. They're not going to be expressed in the same way. What is an issue for one disabled person may not be an issue for another disabled person. And I kind of touched on it earlier, but other life issue education is prioritized because sex is not seen as important. So next slide, please. So for reproductive health, the reproductive health barriers for receiving reproductive health care there are several. Some very practical, like real things, are physical inaccessibility of a provider's offices and medical equipment. Think about it. Accessible, like examination tables. I'm using my personal experience as somebody with paralysis. I never saw an accessible OBGYN table, the accessible exam table, until I moved from California. Living in Georgia and in Arkansas and in Tennessee, I did not see accessible examination tables, accessible like stirrups, or those sort of things. And it wasn't until I came to California and I was like, oh, okay. So And in this photo that I have right here on the slide, this is Dr. Anna Tirado. She is a physician at the Gaylord Specialty Healthcare Gynecological Clinic for Women with Disabilities in Wallingford, Connecticut. And she has, and her clientele, she has accessible tables. She has, things for people with sensory issues. But especially, as you can see, she has like a specially designed examination, table for disabilities that can accommodate a wide range of physical disabilities. So, that kind of access, but also clinician attitudes, the attitudes towards, people with disabilities, and also, like the attitudes that healthcare professionals have towards like communication and those sort of things, but also, just their own personal biases that come into play around disability and sexuality. And also a lot of, and physicians and medical health care professionals, they also do not receive a lot of, if any, education around disability and sexuality. Sexual health education is also, they don't have a lot of hours of those in their training, but especially when it comes to disability, that's not really that hasn't been a large part in the past in addressing that. So you have these as barriers. One, if we could have the next slide, okay, this is a video that kind of explains some of both the physical and the mental health barriers that we're talking about in receiving reproductive health care. So if we could play this video, please.
Okay, so her blood pressure looks like a little low, but it's fine. Can't really do a height and weight right now because, I mean, we just can't. So we'll just skip that for today. Looks like me has been using Depo and just here for another refill. Is that right?
I don't know. I'm just her ride. Actually, my name's May. It's M-E-I. And you can weigh me, actually, but whatever, for today, that's fine.
Okay, well, she'll be in just a bit. Dr. Ernst will be in to see you. So she'll talk to you about that, okay?
Okay.
Okay.
Do you need
so
me
I'm
to
just
move?
gonna. Yeah, I'll do it. It's okay.
No, I can.
No, it's okay. I'm on it.
Okay.
No problem. All right. So.
Okay.
All right.
Oh, she's here.
Hi. These rooms are so small with a wheelchair in them. Let me just.
I can.
Oh, no, I got it. It's no big deal.
Okay.
Hi, I'm Dr. Ernst. It's so nice to meet you. Hi, you must be me. It's so nice to meet you. How are you doing today?
I'm good.
Good. I'm so glad to meet you.
Okay.
So why are you here today?
No, I'm really here because I've been on the Depo shot for so many years, and I was.
The Depo shot works great. I have a lot of patients with disabilities. Has it stopped your periods?
Yes, but I was reading.
So I always find, like, with the patients with disabilities, that it helps them stay cleaner down there because they don't have a period once a month. So.
Well, okay.
And the other thing is, for women with disabilities, well, it stops the seizures. So I think it's a good idea for you to stay on that.
I don't have seizures.
Okay.
But also, like, isn't it bad for your bones? Because I'm not active anymore, so I worry about my bones. And so
Well, I'm not too worried about that. I think it's a good idea to just stay on it to help control your periods. So is there anything else you needed today, or
Well,
do you want me to just put in a refill for that?
one more thing before
Okay.
you go. So a pap smear, I'm like super nervous about it, but I think that it's time.
I
I'm
don't
like
think
30.
you need to be nervous because I really don't think you need it. I mean,
I am sexually active.
you are?
It's kind of weird to have her here to.
You know what? It's better if you stay. I might have some questions for you, or you might need to help us move her later. So I would prefer if you just stay for now.
Just put your earphones on, please. Okay. But shouldn't I have it done at some point? Like, because I really don't need cancer. I've got a lot of
Maybe at
stuff
some
going
point,
on.
but it's really complicated. We could call a lift team to try to get you on the
But
table.
you know what? Minji's great with helping me. Like, I'm pretty strong up here. She can
And
help
the
me
other
move to
thing
the
is,
table.
you know, women who have a spinal cord injury can get this problem, autonomic dysreflexia, and it makes the pelvic exam kind of dangerous. So I'm not sure we need to do that here today. It was so nice to meet you today, and I'll see you again maybe in a year or two, okay? Nice to meet you.
Thanks.
So we got your height and weight outside of the room. I'm just gonna plug that into your chart real quick.
Love the scale out there. It's a lot. It's really easy to roll on and off. So I'm glad to
Great,
have it.
yeah. And then according to your chart here, it looks like you want to talk to Dr. Ernst about whether you're due for a pap smear.
Well, I know I'm overdue and I've never had one, so I'm pretty nervous about it today. So if you just let her know I've never had one.
Yeah, absolutely. And we'll do our best to make you comfortable while we're here.
Thanks.
Anything else I can do for you?
That's it.
All right, so Dr. Ernst will be in just a little bit. I'll go bring this to her.
Thank
and
you.
We'll get you set up.
Thanks a lot.
Hi there.
Hi.
I'm Dr. Ernst. It's really nice to meet
to meet you.
You're Miss Wu?
You can call me May.
Perfect.
Yeah, I mean, my main concern is I've been on Depo-Provera for about 10 years now, and I've been reading it's not good for your bones. That's really the first thing I want to ask you about. I love not having my periods, but God, is this good for me?
Yeah, I understand your concern. There is some data that shows that Depo-Provera over the long term can decrease your bone density. And for women who have another risk factor for low bone density, someone who is non-weight bearing, I actually agree with you. I think that there are better options for you for contraception. Before I tell you what else I'm thinking about for contraception, can you just tell me if you're thinking about getting pregnant and what's your timeline for that?
You're the first person who's ever asked me that, and I can tell you, yeah, when I was a kid, I dreamed of being a mom, but...
And so I would say just because you have a spinal cord injury doesn't mean that you can't get pregnant. I totally understand that. So the thing that I was thinking might be a good option for you is long-term contraception, like an IUD.
But I just didn't think you could do that for me. I've never heard of someone with a spinal cord injury having an IUD.
Yeah, we've done it before.
It's possible.
And oftentimes we can do that right here in the office.
Okay.
I think what we'll do today is I'm going to give you some written information about the IUD. And today we'll try to do a pelvic exam, we'll do a pap smear, we'll do some screening for some infections.
Okay.
And we'll see how you tolerate that.
Okay.
And then if you do okay, we can try to put the IUD in here in the office.
That'd be great.
Yeah, I wanted to ask you before we do the pelvic exam, if you need help or assistance transferring onto the table.
I think I can do it with just a little minimal assist from the medical assistant. I have pretty strong upper arms, or my sister can come help me.
Perfect, yeah, that
too
sounds
hard.
great. Since Minji is used to it, we can grab her and have her help. So before we do the pelvic exam, I'm going to have you empty your bladder. I will go get Minji, and she can help you move over and transfer onto the table. Okay, and then...
Okay, so as you can see, like this video helped explain a lot of, when we're talking about barriers, like one of the first things off was, the scale wasn't accessible for someone that's in a wheelchair. So, wasn't able to get like the weight. So, just thinking of it from the very beginning, from when the patient, comes into the clinic or comes into getting help. And then the how dismissive, because then also we're talking, you can also talk about intersectional issues around like race and culture, not, like the mispronunciation of her name, and things like that. So that also, that's also something to think about. Um, and not, wanting, when I was talking about the infantilizing of people with disabilities and, that whole, how do you talk, talking to her like she was a child, and talking to the other person who was able-bodied that was in there, and like addressing questions and comments to that person who has nothing to do with the patient, so and not listening to the patient talking about the concerns that they had around disability, their particular disability, and birth control. Remember, when we're talking about, you meet one person with a disability, you met one person with a disability. What one person's disability is, their body allows them to have what they can have or what they can do, is different than someone else's body and what they're able to do. Like, I wrote an article, and I have that listed in your resource list. And in that resource list, there are so many things that I would like to cover that, but they are listed in there so that you can have some help in finding these things. But one of the resources listed was birth control and disability. And that was one of the things that I mentioned in the article, was how Depo over time, yes, can reduce your bone mass. So for instance, that's not something you would give a patient that had, for instance, osteogenesis imperfecta, like brittle bone disease, or their thyroid disorders. There are so many different other kinds of disorders that you have to think of, and thinking of different kinds of disability, thinking of different kinds of birth control. And also the fact that, people with disabilities also want to have, families or children, or, pregnancy or things like that. And, these cultural attitudes towards disability and who gets to have children, you can talk about eugenics when we're talking about that, which is controlling who is allowed in society to have children. And that's also in your resource list, and in that resource list, so you can take a look and see, those kinds of things that we're talking about. And eugenics practices are still going on, and people are still being sterilized, against their will or without consultation, because they're seen as undesirable in reproducing. And but then we got to see it being done right, where talking to the patient directly, listening, figuring out how to make it accessible so that somebody can have an exam, um those sort of things. Can we go to the next slide, please? All right, so this is in also the resource packet, the article, and also in the resource packet, I just wanted to say that all of those articles that are listed in all of the academic articles, all of that research is accessible, free, open access, so that I didn't include anything in there that you wouldn't be able to read or access. And this is a framework on disability and reproductive health. So it talks about, somebody, so you can see it talking about like knowledge and reproductive health, communication about the reproductive health, and communication about the issues and the advocacy, self-advocacy and identity, and and reproductive health environment, and in the relationships. And that's kind of a really good kind of flow chart to look at. in providing healthcare. There are also, there's some other factors that sometimes clinicians want to mention, when we're talking about, having to take some extra time and to accommodate, for the disability, and sometimes, people are not reimbursed for that extra time. And so that can be a factor as well. There are, when it comes to reproductive health care, though, but these obstacles and barriers, though, these are things, though, that can be addressed, that can be, that have solutions, and they're, questions and answers that arise, all over the world. So that was the other thing too, is I tend, I like disability is a human condition. It's a natural part of the human condition, right? So therefore, and sex is part of being human. So that means that it is a global issue. So I can look to see what people are doing around the world, because people in different countries address disability and relationships and reproductive health care. They address it in different ways. And so, we can learn from each other in being able to have more inclusive disability and reproductive health care. And now we are here for the questions and hopefully some answers part of the of this session. So, and I'm happy to answer and clarify anything that I've tried to touch on. Thank you.
Awesome. Thank you, Robin. We will move into questions that we have. So again, just before we get started with question and answer, please use the chat and send it to host and panelists. That way everyone who needs to see it can view it. Or you have the option to use the Q&A feature, and in the Q&A feature, you can ask a question anonymously if you would rather do that. So to begin, someone asks, I am a reproductive health coordinator with WellShare International, and we work with Somali and Karen refugees. We see a lot of communication barriers with the healthcare system. Could you speak about linguistic and cultural barriers?
All right, so linguistic, cultural barriers, some of those things, translators, there are, translation apps that, even though having an actual translator is a lot better, but there are, like phone translators, like you can call, I guess, and have like through video meeting and have a translator. That's another option. Or, there are also, like, I've had to use it in other countries when visiting, a phone app, a translation phone app, that's kind of like the last thing that is one way that you can address some of that. And then some other things, though, are just having some education beforehand. If you know that this is a population that is coming, that you service, do some research on your own about those cultures, and about things that learn, like what's taboo, what would be offensive, and what sorts of things are seen as acceptable, and not only that, but just kind of learn about the culture, so that you will know who you're talking to. Like, for instance, if I know that I'm going to be working with a population who, you know, they tend to say that it's that follow Islam. And so I would like to know, like, I would like read about, you know, Muslim do's and don'ts, basically. And in order to address that, like, I would not say we're talking about diet and I'm talking about food and suggesting like nutrition or something like that. I wouldn't say, oh yes, you know, pork tenderloin or whatever would be, you know, a healthier option or something like that, because you're not eating pork, you know, in, you know, Islam, that's forbidden. Just things like that, you know, just, you know, kind of doing some getting basic education, because I know that I'm not being sarcastic, but I'm like, Google actually really is a great resource in finding things. I mean, that's how I found a lot of, you know, the information in finding out, you know, what is out there that exists for reproductive health care and about like accessible things. And I think that that's probably, you know, that's probably a good thing to kind of educate yourself beforehand, especially, like I said, if you're working with this population, you're working regularly with this population, but also having something in place for translation and translators, because communication is key. Communication is key to being able to assist and provide proper services and care to people. So, and you want to be able to understand, and you want them to be able to understand you and the advice that you're giving.
Thank you. That same person put into the chat, I agree there is a need to research the culture, but what the healthcare system providers could do to educate themselves on how to deal with different populations. Any ideas?
Things like this, attend different seminars. Like, for instance, right now, you're educating yourself on how do I address disparities in disability and reproductive health care. So, you know, we have, you know, continuing education. That's one idea. And I know you're like research culture, but let's see. But also, you know, you can research because there's a lot of research that healthcare providers have done, or people that are researching things that, you know, that are issues for healthcare providers. I did a Google search because I will have to say that because I do a lot of research in my work, and I do a lot of independent research. I have found that I can just type in the topic and, you know, exactly of what I want to know. And like, say I wanted to know healthcare disparities in disabled South African individuals. And it will pop up, and, you know, there will be different articles, there will be different, you know, academic journal articles where people have asked these questions and researched and found answers, or found what needs to be answered. I'll put it that way. And you'll see that actually in the resource list, the resource and bibliography list that's going out. You'll see what I'm talking about. And basically other providers are answering and surveying and looking at what information is out there to provide education and to provide actual real health. Like, I was reading something where they wanted to know, how can we use Medicaid waivers and stuff in order to in order to provide sexual reproductive health care. I mean, that was something that came up, that I saw, and I was like, that's interesting. But that's those are some ideas that I have right here, like just offhand.
Thank you. Our next question is, what are your thoughts on communication with caregivers or supportive parties in regards to reproductive health care for clients that may have difficulty with language barriers, developmental delays, etc.? How is this best approached?
Okay, there are, so this is like you have to realize when it comes to communicating concepts, you need to meet people where they are and how they understand things or how they access information. So, and so that means you need to embrace different learning styles. Some education that I've seen, because when we're talking about like sex education for students with disabilities, how are you communicating, concepts to people who are nonverbal or who are not able to read written language, or even not even just like saying, somebody that it doesn't speak the language that you're educating in, or whatever, like so I have seen where people have used things like photos, these pictures, like illustrations, in order to depict what is going on, or what, to educate, like around, like say a menstrual cycle, and then educating for, like what you can do, or different kinds of, like what exactly, kind of like what is happening, showing, like the pictures of blood, and, vaginas, and, just kind of that sort of thing. I've also seen plain language, like written literature that's in plain language that people can understand, using the vernacular that is, common and understood. So maybe using phrases and terms that are understood, like saying maybe boobs instead of mammary glands, or or saying, things like that, as an example of trying to give a kind of a soft example. But but you also have to think about, like, say if you're trying to educate people who cannot see, and this is where we're talking about like 3D models of say genitalia, or models of like trying to demonstrate about I'm trying to think. I have a friend, that was the other thing. So you can research. One thing, one site that I found a lot of really great information was on Teachers Pay Teachers. And so basically, your peers are also very great educators in doing what you do. So Teachers Pay Teachers, they had sex ed resources for teaching people with disabilities, and teaching in special ed classrooms about sexual health concepts. And it was curriculum and lesson plans and all of that. And it's very affordable, cheap resources that you can buy, that has all of this. It has all this information. Now, some of it is, you actually have to look at it, because some of it I looked at and I was like, that perspective is a very shaming perspective. Like, I saw one, it was using a story basically to educate about masturbation, but the way they framed it was called like keep your hands out of your pants. But the way that they phrased it was, touching yourself was dirty, and you don't do it because it's nasty and other people are offended, rather than doing it as a, yes, it does feel pleasurable, but rather than going into, but this is not the place where we do this. This is where you can engage in this behavior, but we don't do this here at school, or whatever, but not, is that, so you have to kind of look at it from that perspective as well, and seeing how you want to communicate what's the lesson, what is it that you're wanting to communicate, and to communicate it in a way that addresses the autonomy and the right to people to have sexual, to be able to express their sexuality. I know what I'm trying to say, it's coming out kind of jumbled, but it's one of that in a perspective that addresses your humanity, and is also respectful of the fact that you have autonomy as a human being. And hope that answered that.
Thank you. Okay, the next question is, can you share clinical best practices healthcare professionals can use when caring for folks with disabilities, both visible and non-visible disabilities?
All right, I am going to pull up this said resource list so that I can share directly, because some of this stuff I'm like, wait, I've got that in the resource list that I can share with you. Wait one moment while I pull that up, and then I can give you an answer. One second. Robin, go to your Word documents. Okay, here we go. Open it. Okay. Now, no. I just want to move this. All right. So, so it was, the question was for, can you repeat the question so then I can find that again?
Yep. So can you share clinical best practices healthcare professionals can use when caring for folks with disabilities, both visible and non-visible disabilities?
Okay, one resource that I thought was really good, Disability Inclusion and Reproductive Health Programs, an Orientation and Values Clarification Toolkit. That resource was really good and kind of broke some of that down. Another one for physicians, Sexual Health in the Community, Services for People with Intellectual and Developmental Disabilities. And another resource was talking about, it's in ResearchGate. It's the extended implicit model, which is a model for addressing the sexual well-being of individuals with acquired disability or chronic illness, but it's set up, for clinicians or providers, a way for them how to address that. And I briefly touched on that when in my presentation, when I had the reproductive, that was developed by clinicians, that model of the reproductive healthcare, that chart, the conceptual framework, that was developed by clinicians. And another resource, I have supporting, a lot of this, I noticed that there was a great deal of research when they're talking about reproductive health care and providing reproductive health care. A lot of it was centered on supporting disabled women. or female bodied or people with uteruses, and supporting that. But this is that, but this one is supporting women with disabilities to achieve optimal health, is a health equity features from the CDC, and it had some information, and there's several articles in there in the resource list that listed that basically did a review of all of the literature and all of the findings that are out there for clinicians addressing working with populations of people with disabilities and reproductive health care. And so they've gone over all of those kind of things. And as well as talking about there's the AMA Journal of Ethics had a reproductive rights and access to reproductive services for women with disabilities. And that was, directly speaking to other clinicians and things like that surrounding, about the rights that people have and around and how to access that in reproductive services. Did that help answer?
Thank you. Our next question is, well, it starts off with a comment. Thank you, Robin, you are wonderful. I am a woman and gender-related NP student looking for better person-centered contraceptive counseling tools and methods. We do not talk much about hormonal contraceptives and their impact on blood sugars for folks living with diabetes. Is there a resource you like? Additionally, I am working on interrupting the BMI and replacing it with HAES, health at every size. I am wondering what your thoughts are on clinician fatphobia are.
First off, I love it. I'm like, wow, that's amazing that somebody is working in this area. Second thing is, I'm going to put it this way. I wrote that article in 2017 about what you should know about birth control when you have a disability. It's still the only one it's still the only article that's, if you do a Google search, that is just written, by someone else outside of the medical field. And if for those kind of things, I had to Google all this stuff. I had not found, that wasn't even anything I'd heard addressed. And now I'm going, oh, that article needs an update. I did not know about the diabetes. Of course, that would affect the type of birth control. I don't know why that hasn't popped up. To be honest, a lot of this stuff, until somebody else brings it up and until somebody, asks these questions, then, they're not answered. So, okay, so the first thing, I'm sorry, I'm still stuck on diabetes and birth control of that part of the question. I personally, that's the first time I've heard that question, and I think it's awesome. And now I'm going, after this call, I'm going to research it, and I want to, so that I can follow up and ask about including that as an update to the article. But the second thing, okay, can you ask me the second part of the question again?
Yep. So wondering what your thoughts are on clinician fatphobia.
Oh, as someone who also identifies as fat, and where clinicians want to say that it doesn't matter what is going on. Oh, my arm is broken. Oh, well, you need to lose some weight. It's that totally needs to be addressed. And I think about that, because, if we're looking at the definitions of disability and different perspectives and model, I feel that fat bodies fit in that perception of the social model because of the barriers that are presented. And those barriers are, there are physical, like barriers like seating, medical equipment, that sort of thing. But also, the attitudes that people and, like I say, clinicians are, products of their culture. And you have this fatphobic culture. And so that is also echoed in the medical care that people receive. So that needs fatphobia, and that has to be addressed. That has to be addressed because people, your size is your size. You have health problems that have nothing to do with your size, and those things have to be addressed in the same way, with other disabilities, when we're talking about like birth control and with or having, or fertility, or or talking about checking for cancer, or all of the other things that people need healthcare for. But fat phobia greatly impacts that healthcare. From my own experience, yes, there have been things that have been missed due to my size, because health care things that have been dismissed due to my size, like migraines. Losing weight is not gonna erase my neurological the neurological things that are going on that cause my migraines. That those are all, it's all entwined, it's all together, because the things like not only like your size, but also culture, your race. I can talk also about the intersection of race and the impact that it has on your medical care and receiving medical care as well. I think that we are more familiar about the disparities in Black women's reproductive health care, and how they receive it, and our rates of like infant mortality and things like that, and maternal mortality, because we're not, in the medical community does not treat our issues the same as they do someone who is not Black. So yeah, all of those, your identity, it impacts your medical experience. How you physically present, it impacts, the type of healthcare that you receive. And, hopefully with more education and more talking, like what we're doing right now, we can help, lessen and eradicate, those kinds of disparities, due to those biases. But yeah.
Thank you. Our next question is, how can we assist disabled clients that may fall under mandatory reporting for sexual activity as a person that cannot grant consent per law?
Okay. All right. So you're talking about someone that is like under guardianship, or okay, can you ask that question again? Because I'm like having to shift thinking.
Yep.
Okay. So about consent, ask it one more time, please.
Yep. How can we assist disabled clients that may fall under mandatory reporting for sexual activity as a person that cannot grant consent per law?
Now, this is where we're getting into like talking about autonomy and talking about rights and access to rights. And, that looks different depending on where you are. I know that y'all are in Wisconsin, and that the laws around that might be different, but saying, okay, so mandatory reporting, saying that, so are we talking about someone saying it's reported, you have to report that somebody has had sex, or you have to report, or are you saying mandatory reporting for abuse or sexual abuse? Or are we talking about, I don't know exactly what we're talking about, but are we talking about like under guardianship, like say someone is in a nursing home or something like that, and say they've contracted like an STD, and you're like, okay, how did this happen? So having to report that, I guess I'm a little, I just need a little bit more clarification before I can feel I can give a definitive answer.
Yes, so that question came in anonymously. So if you were the one who asked that question, if you want to clarify a little bit, we will wait for that and move on to this next question before while we wait for that information, because it did come in anonymously. So I have no more information than just asking the question. So we'll wait and ask the next question. Okay. I love Dr. Toronto's access table. I anticipate working in LHD or FQHDs with limited budgets. Is there a grant to get these awesome tables for clinics pressed for money?
That I don't know. I will tell you that. I just think that I found information, but I don't see where there wouldn't be some kind of grants, because I'm noticing like the Ford Foundation they now have a philanthropic division around disability. And they have a whole division. And so talking about it, because last year I did a talk with them because they're wanting to provide more support for reproductive health care, and so reproductive health care and disability, and like parenting and disability, and around sexual health care, a disability. I think that they're probably, I would check out like the Ford Foundation. And if, what? Because I know somebody that just, became like the director of that division of the disability, for like grants and that sort of thing. So I think that would be an amazing place to start. But yes, I don't see why there wouldn't be grants, because like I said, I did a talk to where the Ford Foundation was talking to other philanthropic organizations out there that want to address these kind of disparities. So yes, I'm sure that they do have grants. I know that some of the grants may seem like more general, but like kind of generalized, but being able to utilize it for equipment and things like that, I think that would be amazing. an amazing use of those grants. And so I would suggest, and if you feel comfortable, being able to ask me that, if you can maybe send me an email at robin@robinwb.com. So then maybe I can pass that information on to my friend who is the, like I said, she's now the new director over their disability philanthropic arm. So if at Ford Foundation, so, because I think that's a really great idea, and there needs to be, and how can, in order to, make these things accessible and things like that, and in order to serve more populations, then yes, you need money in order to get these kind of equipment in order to make it more inclusive. I don't know how we are on time, but.
And we have about 10-ish minutes left, a little bit under 10. So we have time for a couple more questions. So next one is, how do you get operational buy-in from leadership to address physical barriers in accessing care? For example, investing in accessible exam tables, scales, etc.
I think one of the ways you can do that is by actually having patients coming in, like having to talk about these things and talk about, sometimes like the most powerful way is actually hearing from the populations that are affected themselves, that whole nothing about us without us. Fine, if you're asking, for assistance like this or whatever, having someone who is a patient, who is utilizing your services, who has encountered, this barrier and the impact that it has on them, and why they need this equipment, or why it would make it better, make the clinic better and more inclusive. In order to get them to have that buy-in, you need to involve people with the disabilities to talk about that. But your disabled patients talking about that, but also just the buy-in and talking about how, you can talk about like the population of people who are, disabled. You can talk about like percentages. It seems to fluctuate all the time, I guess, depending on what, how you define disability. Sometimes you see like 1 in 5, 1 in 3, people who have disabilities. But, then you can go and, find statistics and talk, but you also can, but you can also say that it's just better for the bottom line anyway, because, disability is just one of those, conditions that, it can occur at any time in life. You might have a patient that is able-bodied right now, but, they can, have a traumatic type of accident or something. Like, for instance, we saw in this, in the video that we saw earlier, we saw someone who, had been injured in a car accident and, acquired a spinal cord injury from that. So that, that's something that can happen at any time. Your patient may be walking today, but they may not be walking tomorrow. Depends on what happens. Life happens, and not just, accident. You have cancer, you have, strokes, heart attacks, all of those things that can impact, your physical body. And so, just talking about that it's kind of a good, what I'm also talking about like inclusive design and tech and things like that. And it's just like, you have to think about inclusion from the beginning. But trying to get that, but I know that getting that buy-in and talking to the powers that be that control budgets and things like that, your presentation and talking, because I assume, it's not going to just be a quick email and saying that, hey, we need some accessible tables. You know, you need to kind of have explain why and how this would benefit, you know, overall. In the buy-in is showing how, you know, having this and being more inclusive is better for your patients overall, for, you know, in entirety, because, you know, it helps provide like a lifetime of care. But that's just one way that I'm thinking about it.
Awesome, thank you. It looks like we have time for one more question before we wrap up and I give some final just reminders. So our last question is, are there recommendations for mitigating concerns from parents, guardians, or caregivers about reproductive and sexual health care provided to adolescents with disabilities?
Okay, there is a book, and I didn't, you know, that because I was looking at it perspective of for nurses, and I didn't think about that part of talking to parents or, you know, of younger people, but I do have a resource. Give me just a second. I will find that book. There is a book actually that came out in talking about how do you talk to parents and about sex education and about sexuality for their children with disabilities. And just give me a moment and I will find that. Hold on. Okay. Oh, you know what? Ding. Just look for bookmarks. Bookmarks, bookmark manager, and disabled youth sex ed. Here we go. All right, and here we go. No, that's not it. Teaching parents about sex. Okay. I'm just finding that book. I was just like, because it just came out last year.
Robin, while you find the title of that book, I'm just gonna give a quick few reminders to folks in case you do have to pop off right at 1:15. But after this webinar concludes, you'll receive an email from HCET, which will include an evaluation to today's webinar, as well as that resource list that Robin has been referencing throughout the presentation. So you can go back through that and look. It also will contain the nursing contact hours form if you are wanting to obtain nursing contact hours for today's webinar. So that information will be in that communication as well. So those are just a quick few reminders for you all following this webinar. And the link to the survey was also put into the chat by my lovely coworker, Jordan, if you would rather access it that way.
Okay, that's not exactly the book though that I was trying to find though. I found one resource, but that's not the one that I was looking for. That one is a guide for parents, but
Robin, if you want to find it
yeah,
after the webinar, and then we can.
Yeah, can I go ahead and do that? because then I can like submit that to you and you can submit that to that person, because that's a really, that one, you know, because that is great. Because a lot of times, yeah, parents are, because they're thinking, this is my baby, blah, blah, blah. And so they're, when it comes to sex ed, but, teaching parents, the importance of teaching sex ed to their students with disability and how to talk to those parents. Yeah, that's different. So yeah, I'll find that. I'll find where I had bookmarked and put all that stuff, and then I'll give that. I'll send that to Megan, and then she can send that to y'all.
Awesome. Thank you so much. And again, that will all be included in the follow-up email following the webinar with all the information that you will need after this webinar concludes. And I want to thank you, Robin, for a wonderful presentation and a delightful question and answers segment of the webinar today. And thank you, everybody, for your time and participation, and have a wonderful rest of your day.